everyone. So great to see everyone today. Thank you very much for coming. And thank you very much to our speaker, Susan Cassels, who is here today to talk to us about things that are just as important today as they were yesterday, at least. Susie is a geography professor and director of the Broom Center for Demography at UCSB. She got her PhD from Princeton in demography and an MPH in epidemiology from the University of Washington, where she also spent some time as an assistant professor in epidemiology and global health. Her work largely centers on mobility patterns and how they're related to HIV transmission and prevention among various groups in the US and in Ghana. And so thank you very, very much for coming today.
Thank you. Okay, so is everything set up here? I don't have to do anything. Okay, great. Well, thank you so much for showing up today. It's really my pleasure to be here to talk a little bit about the study that we have. Well, so this is the first kind of paper from this grant, and there's a lot more that I'm excited to do. So I would definitely encourage. I would love to hear your feedback and suggestions about what else we can do with these data. Okay, so let me figure out how to get started. Let me also say that this is a collaborative effort with a lot of students, faculty at UCSB, and a lot of people here at UCLA. Pamina Gorbach and Steve Shoptaw are the PIs of the kind of mother grant that we are using data from. And unfortunately, Pamina is teaching right now on the other side of campus, so she couldn't be here. Okay, so today the main aim is to describe the original kind of findings of our study, to identify, describe, and assess the overlap of different kind of types of hotspots related with lifestyle hotspots and kind of places where people access care or healthcare hotspots from a sample of sexual minority men here in LA. But through that, I also wanted to just describe our study, talk about how we went about collecting our data, demonstrating our approach, but then to think more broadly about kind of spatial contexts and geo-social determinants of health, how that might be affecting health, but also how we can think about health interventions from a spatial perspective as well. Okay. So to start off, I thought I would just kind of take a step back and say almost all of my research is informed by this idea of geo-social determinants of health, how space and how our social context really does drive our health, and how there are these things, called the fundamental causes that affect our health. So really thinking upstream about how there are things like racism or poverty or these other structural drivers of health that affect and determine health disparities, even if the intermediate or the proximate determinant changes, right? So this is also important for sexual and gender minorities because there are things like, homophobia or other stigmas that might be really important to drive health, even if you, say, intervene on HIV testing or some other health intervention or substance use harm reduction strategy. So really thinking about these different levels of drivers is how I think about most of my research. And this is the sexual and gender minorities health disparities framework, which is also really a socio-ecological model. So thinking about individual characteristics, but how those are, they intersect and they are affected by other, levels in space and context. So interpersonal factors is the next one, community level factors, and then other bigger kind of broader social drivers. And then one last thing I wanted to mention is my future work is going to be thinking a little bit more about historical drivers of structural exposures in LA using these data. So we just got another R01, that's my first, to think about some of these different neighborhood patterns and how they may have been driven by historical drivers and policies. Anyway, so I just wanted to start off just thinking about the framework in which I'll be addressing this. Oh, one last thing is the minority stress theory is something else I bring a lot into my work. And that's the idea that, stigmatization for sexual and gender minorities or for any other minoritized population, the stress that may come with exposures to these levels, interpersonal, social, structural levels, is one pathway in which, space and social context can get under the skin and affect health disparities. So that's something else that's really important to keep in mind. Whether it's actual stigma or perceived stigma or something like that is important to think about. Okay. Okay, another kind of, yes, please.
Sorry,
Yeah.
the fundamental cause here.
Yes. Yeah, so thanks. So I actually, when I teach social determinants of health, I always start with this paper by Bruce Link and Joe Fallon, which is talks about racism as a fundamental cause of health disparities. And so the idea is, let's take racism as one fundamental cause. There are other poverty, inequalities that can lead to health disparities. The idea is that if people experience racism, that can lead to unequal health outcomes. But there's other things that affect the path. So like unequal access to education or differential vaccine strategies or, lots of things that are intermediate drivers. Say you have an intervention that changes that intermediate driver, makes it perfectly equal. Racism will still affect health outcomes through some other mechanism. So it's a fundamental cause. So if you really want to improve health equity, this theory argues that you have to go upstream to those fundamental causes. Thanks for clarifying. Yeah. Okay, so activity spaces. This is Reg Golledge's idea from 30 years ago, that there's a set of locations which individuals are routinely exposed. And this can be social networks, other networks, environmental factors, political factors. And in my case, I'm thinking about HIV as the outcome, but it could be, you can think of how activity spaces can affect the health of any, health outcome that you're thinking about. A lot of people think about it as like home factors, but also where you go to socialize, work, play, family, that kind of thing. But what I wanted to talk about is that that originally people thought of activities or geo-social factors of health as like where somebody lives as their neighborhood, and that might affect their health. But there's actually, it's important to think about the idea that there's many different places that people go throughout their life course, throughout their day, that affect their health. So Stephen Matthews came up with this term called spatial polygamy, which I find kind of interesting since I do work on HIV and health, that asserts that people experience and interact in lots of different contexts. And these varied contexts may affect health in different ways. And actually, looking through this a little more deeply, Matthews mentioned that actually this concept was first introduced by a professor of geography here at UCLA giving a talk, John Odland. So I didn't know that, but turns out a lot of these concepts really did originate here at UCLA. So one of the other things that was really great, published in about 10 years ago, Malia Jones and Ann Pedley demonstrated that neighborhood effects need to think about other characteristics of activity spaces. So it's not just where you live that affects your health, but you need to, and actually they demonstrated using data from other activity spaces. And then I thought, if this is something that many of you are interested in, I suggest you look at the Sharp and Kimbrough paper that they, I thought, really did a good job demonstrating in the case of diabetes that these exposures, whether it's at a residence or some other activity spaces, can actually affect your health through synergistic ways. So it's not just the characteristics of your home neighborhood, but it might also be the characteristics of your work neighborhood that may, add on to a health exposure or protect you as well. So you have to think of these interactions in a synergistic way, which I thought is important to think about. Okay, so that's all great and all, but how do you actually collect data on these activity spaces. There's a lot of different ways, you could follow people with track their using GPS or cell phones or kind of geographic momentary analyses or ask people. But it's important to think about all of the different ways that you can collect these data. And I think that's really important in the field of population and health and geography moving forward. Okay. So my work is mostly with sexual minority men. And as I was thinking through this project, I thought this idea of spatial polygamy is especially important because we know that sexual minority men are exposed to different structural factors in their residential spaces versus their non-residential spaces. And some past work has also suggested that there is actually historically little concordance between these places. So the Dragowski and the Koblin paper both suggested that maybe 30% of their activity spaces were congruent, of places where sexual minority men engaged in sex acts or socialized places or home places. And so that actually is really important because there might be certain drivers, right, that maybe certain places are stigmatized, or the distributions that people need might be in different places. So to think about these different activity spaces with the specific population in mind is really important. So the non-residential exposures are pretty important in health research for sexual minority. Yes.
I'm just stuck on the 30%.
Yeah.
Is that like, I guess I'm wondering if those are national data?
Oh,
or,
yeah.
Restricted to a specific area where, I mean, we know cities differ.
Yes, that's such a good point. Thank you for reminding me. Both of those were in New York City. So this work hadn't really been done in a large, spread out metropolitan place like LA. Yeah. So our hypothesis is that these places will not be concordant. Turns out we're kind of wrong. In LA, maybe that's different. But that was what drove the hypothesis, is that people would maybe, and also times have changed, especially for minoritized or sexual minorities. 10 years ago, maybe there was more stigma to, show up at a gay bar or go to an HIV testing place. Maybe that's less stigmatized now. I don't know, that's up for argument, but. Any other questions on these concepts? Yeah.
So, when we talk about spatial polygamy, is it the idea that I'm engaging in all these different places where I conduct myself differently?
That's a great question. It does not assume that you conduct yourself differently in those places. It's the theory is just that these places that might have a different exposure on your health. But that's a good point, because if in one place you're sitting in an office inside, and another place you're with your kids at a park, the way that the geography can affect your health is different. So that's really important to think about. Okay. See. Okay, so before we conducted our study, we did a qualitative survey, again with the M-study data, and I'll introduce that in a few slides, where we asked sexual minority men, mostly Black and Hispanic men here in LA, about where they go and what they do over the course of a day. And we published this paper where we found a couple of things that kind of led to our hypothesis that places did seem to be incongruent. And we also found that a lot of the men we talked to were highly mobile. A lot of that was mobility within LA County, but they said, oh yeah, I moved from Texas, but then, I lived in Long Beach, and then I went to this place, and then I went to this place and this place. So it seemed to be that they were very mobile. And and also it seemed from these interviews that many men did not feel connected to where they lived. So kind of a place detachment, right? So one of the men said, this is just where I live. And I live my whole gay life somewhere else. So it seemed to be that people were not very connected to their neighborhood, and that the places that they went to engage in social lives were different than their residential neighborhoods. One man said, there's not like gay stuff there, but then again, I kind of live my whole gay life somewhere else, not in my neighborhood. And also, although I'm not going to talk about in this talk that it seems like the geography of sex, kind of where people engage in sex, where their partners live, where they live, and how they meet, has been changing a lot with, things like Tinder and Grindr and geo-social hookup apps. So that's something we talked about a little bit in this paper. But there are these, larger factors that may be contributing to different patterns of movement and spatial exposures. Yeah.
In this survey and in the later work that you do, are you focusing on participants that identify as gay men or sexual minority men, or are you able to?
Yes. So we recruited individuals for this qualitative study from the M study, which I'll introduce in a minute. And the M study has eligibility requirements. They self-identify as gay or bisexual. Yeah.
So does that mean that when they choose where to live, it's not a criteria, that the place is more or less discriminatory? So
we did talk about that, like, why did he move to your neighborhood? And a lot of them weren't necessarily intentional choices. It's just, given the housing crisis in LA, it was like what was available. Yeah. Okay, and a couple more introductory slides before I get to the study. I also just want to put a call out, like queer demography is really important as demographers to start thinking about. The number of individuals in the US who consider themselves something other than heterosexual has more than doubled in the last 10 years. This has really been driven by cohort effects. Over here, you see baby boomers, Gen X, millennials, Gen Z, and the proportion of individuals who identify as something other than sexual or heterosexual and other gender categories is increasing significantly. So this is really something that we as demographers really need to think about. And I feel like a lot of studies in spatial demography and health have been pretty limited. One, the census still does not directly ask about sexual orientation or gender. There are some other studies, national studies that do, but there's still, limited data out there. And also a lot of the work I do is around sexual minority men and sexual health and HIV. And that kind of, because of the HIV epidemic in the 90s and the 200s, a lot of the work on sexual minority men was engaged around sexual health. And that has kind of, in my mind, led to a bit of a hangover in the sense that a lot of health research is just now coming out on the health of sexual minority populations, more broadly. So I do think that's something that's still ripe for a lot of research. The population research at the Office of Population Research at OPR at Princeton had a queer demography summit. This was maybe 6 months ago now, but it was really excellent. I was so pleased to see this. And they kind of had research on fertility and mortality and health. And there was very little on migration and spatial approaches to some of these topics. So I do just think that there's a lot of work that still needs to be done. Okay. Last one. Okay. And so a lot of my work is engaged in HIV research. And when I wrote this grant, I embedded it in this idea of hotspots and ending the HIV epidemic. So among everyone living with HIV in the US, I believe like 70% are sexual minority men. We see massive disparities by race and ethnicity. We see incidents of infections staying kind of flat for the most part, declining among white gay men, but not among a lot of racial minoritized gay men. So there's still a lot of work that needs to be done. The ending the HIV epidemic came out as a goal for the US to reduce the number of new acquisitions by 75% by next year and 90% by 2030. And the idea is to, diagnose more quickly, treat more quickly, protect more people, and respond more quickly to new clusters of outbreaks. And one of the ways that they plan to do this is to identify hotspots. So there's ending the HIV epidemic places that they have identified. LA County is one of them broadly, but there's like 20 some places in which they feel like they need to target or give more money to. But a lot of the other hotspots are identified as places where people more people are living with HIV than otherwise. So that's the idea. That's how they define hotspots. But I thought, well, is that really where we want to look, right? Especially if a lot of sexual minority men don't feel connected to their place of residence and they're engaging in potential risk factors elsewhere, we should identify these hotspots as places where, you know, HIV transmission or acquisition risk is higher. So that's kind of how I pitched these ideas to do this study, that we need to identify hotspots of other things, not necessarily just where people are living. Okay. How am I doing with time? Okay, so the objective of this work is to identify, describe, and assess the overlap of these places where people do things, activity space clusters in LA County, mostly among Black and Hispanic sexually minority men, and we'll call these hotspots. First, we identify them and examine who is actually engaging in behaviors in these hotspots. Then we test to see whether they overlap in space. And then lastly, we explore them more broadly to be like, well, okay, we see these overlap of hotspots in the downtown area. How is that different than the West Hollywood area? And if I were to, say, identify an intervention strategy, how would it be tailored? I do expect there to be clear clusters emerging based on different sociodemographic characteristics, but I also expected these places to be incongruent. So, you know, the home activity places to be different than the sex, substance use, and other places. But it turns out they're not exactly. Okay, so the mother grant is this M-Study grant. PIs are Steve Shopton and Pamina Gorbach, who's a CCPR fellow. It's been going on for about 10, 11 years now. It's called the M-Study, and it's not a representative sample, so that's a big caveat. But they identified sexual minority men, mostly Black and Hispanic men in LA for recruitment, and also people who use substances. So among the M-Study cohort, about half are living with HIV, half not, and about a little bit more than half had identified or self-reported that they'd used substances in the last 6 months or so.
Can you talk a little bit more about the sampling? For those of us not familiar, like how are they getting, I know you said it's not a random sample, but
No.
okay.
Yeah, they just advertised through the LA LGBT Center,
Okay.
the Vine Street Clinic, and newspapers, harm reduction intervention places. Yeah, so it really is kind of a, what do you call it? Convenience sample.
Yeah, but I guess I'm convenience selected on what? So people care seeking? What is the, so I mean, I know like a convenient sample where you're thinking about like mental health, like if you were just kind of drawing people who've all gone to get care for depression or something at a clinic, then you kind of understand how it's selected and what it represents. So can you tell us more about this one? How do you think it's selected?
I don't know if I have a good answer for you because the study started like 12 years ago. And they've been kind of increasing enrollment for the people who dropped off.
Oh, I see.
In
So
a
they
sense,
continue
they're
enrollment.
continuing to enroll. So I don't know if I would be able to clearly define that for you. Maybe I wish Pamina was here. She'd be able to say that. Yeah. That is a good question. I'm sorry, I don't have a good answer for you. Yeah, in the back.
Just one follow-up question. Can you explain the difference between, or maybe you can give me an example of two congruent spaces? I just want to be clear on that.
Okay. So say we have data on where people said that they lived. And we do our, GIS magic and we make a little circle and say, this is the activity space. And then we do the same thing. Where did you last have sex? And we find like a hot spot and we draw a circle. Do those circles overlap or not?
Oh, okay, cool.
Okay, congruence, overlap, incongruent, separate.
So it's based on, at least two spaces and it's just wherever they overlap. Okay,
Yes.
great. That makes
Yeah.
sense.
I know you've already answered Martha's question, but I guess I want to make the connection to the policy implications.
Yeah.
Because if you want to identify the locations where people are most at risk.
Yeah.
But you start off with people who have already experienced risk.
Yeah. So that's a big caveat in our limitations section. We're saying if we were to define an intervention for higher risk Black and Hispanic MSM in LA that are part of the study, here's what we do. If we wanted to do it more broadly, we'd have to repeat this with a representative sample.
Well, or sort of a parallel sample.
Yeah.
But I guess I'm
part of my question is about sometimes a convenient sample is exactly the sample you want, right? If you're thinking about intervening for people that are seeking care, like at the point of care seeking, that's the perfect sample, right? And you don't care that it's selected that way because that's exactly how your intervention would be done. But on the other hand, if you want to generalize to that group, but you're not recruiting from I think it really depends. And so that's part of,
Yeah,
I'm not sure you need a separate study to think about policy, but in terms of thinking about policy and how you understand what you're learning,
yeah,
it would be helpful just to know, how you're getting these.
Yeah.
Enroll.
so the recruitment was, HIV, people living with HIV and without, young Latinx and Black men. Inclusion were age 18 to 40, willing to provide samples. Recruitment procedures included distributing flyers and providing in-services to agencies that provide services to gay men. LGBT Center, Vine Street Clinic, substance use treatment sites, and other community settings. Advertisements placed on the internet like Grindr, periodicals and media read by sexual minority men who use substances, and direct referrals from agencies. So I had it written down.
But even by thinking about, like if there's differences that you could identify based on sort of the group. So some people who
Yeah.
are recruited from Grindr, I might expect to be very different
yeah.
than the people you're recruiting
Right.
from certain types of clinics.
Yeah.
And those things are really interesting and informative.
Mhm. Yeah, maybe we could stratify those later. Yeah.
She said.
Well, but also our sample for the study is relatively small. So as I mentioned, the M study is ongoing. They had 335 visits in the last year, but ours is only 219 men. So what we did is we recruited men who were already enrolled in the M study to do one extra survey, this activity-based survey. This was based on an R21 that I got. And the idea was to determine and prioritize places where we could do HIV interventions. So the whole hotspot thing, right? Not just where people live, but maybe where other activities take place. So we created the survey. We did 8 or so cognitive interviews to validate it, to understand how it worked. And we published a JMIR article, just really defining the specifics and how we kind of finalized this map. So men would first see this map and they could click on a region. It would zoom into that region. They click again. And then the third would be this map where they could search and then drop a pin. Recruitment happened and finished about a little more than a year and a half ago. But one of the things was, we were asking about potentially sensitive places, like where did you last have sex? Where did you last use substances? So one of the things we did, and I didn't include this here, is we asked men after this to say, I told you exactly where this was, or I intentionally jiggered it, or I didn't really remember, so I just guessed. And I have a student now who's looking at the spatial uncertainty and whether that connects to both who the person is, what data they're reporting behavior on, and actually where. And she's seen interesting patterns on more or less uncertainty on all 3 of those characteristics. Okay, so what we'll talk about today is 8 location types. So and I don't like this term lifestyle locations. I couldn't think of a better one. If anyone has a suggestion, it's kind of like healthcare related stuff and everything else. So we have where you lived, where you last had sex, where you last used substances, and where you last socialized. And so those we're going to use. Although we asked up to 3 locations for like sex use and substance use, we're going to use only the most recent for this first try. And then we also ask about where, when you went to see the doctor, where that was, where you last went to a pharmacy, where you last had an HIV test, and where you last had an STD test. Yeah.
I'm just wondering about the absence of work.
Oh, we asked and we didn't include it here. It was actually. We also worked about work and school, and it just didn't have a lot of interesting information. And so for this first cut, we didn't include it. Yeah.
So I'm just trying to understand what interesting information would be.
Well,
like if it's close to where your pharmacy is.
Yeah. I wish I had the numbers with me right now. We had much lower response rates for work, but also work is weird these days, right? Like if you're an Uber driver, where do you work? So we just dropped it, but I guess I should have a better answer as to why we dropped it. Yeah.
I think your comment about what does work mean?
Yeah.
Right?
Yeah.
I mean,
Yeah.
so do you know what kind of work they do?
I do, and many of them are unemployed at the moment.
Yeah, that's.
Yeah.
that's the reason that force
Yeah.
location isn't
Yeah.
very
Yeah.
helpful.
Remind us, gonna ask
Okay.
the chair that was engaging gig work.
Okay. Yeah, I don't have that number in front of me right now. Okay, so some methods. So first we have the geolocated point for all of these activities, and we use DB scan as a clustering method, which is, fairly, it only requires a couple of different assumptions. It's basically, you have a number of observations around a point, and then you say, do you see more of those observations than expected if they were just thrown out randomly, or are they higher than you would expect? So you need to know the number of points that's the threshold, which is 5 in this case. And then you need to know the area that you're talking about. And so for that, it's a little bit more complicated. We use 0.6 miles, which is actually what one of my students finalized after he did he used ACS data to try to use a clustering method around racial neighborhoods in LA to get a sense of how big are the clusters of kind of racialized neighborhoods as to neighborhoods that have more Hispanic, more Black, more non-Hispanic white individuals. And so that was the threshold that we decided on. We have not done sensitivity analyses yet to see how that would change if we change those two assumptions, but that's just the basic idea of how we came up with the clusters. And then to assess overlap, we created convex hulls, which is defined as the minimum boundary of a polygon that contained all of the points in a cluster. So that, think about drawing just kind of a polygon around those clusters. And then we just did a quick, overlap calculation. So you have home and sex, how much those overlapped, and how much of a percentage of home that is. Okay. So that's how we defined that. So let's get into some of the results. This isn't all of the data, of course, but just to give you a snapshot of our socio-demographic characteristics. At this point, the cohort has aged a little bit. They were younger when they first started getting recruited 12 years ago, average age of 37. As I mentioned, it was originally prioritized Black and Hispanic individuals. So I think only about 10–11% were not identified as non-Hispanic or non-Black. More than half of the population in the sample was living with HIV. Education is as you see here. People who reported using substances within the last week was 45%. And there's a lot of people worried about housing. So 34% worry a great deal or a lot. And 16% are cohabiting with a partner. Because that's also important when you think about where does sex take place? Is it at home or not? Yeah.
Do you know off the top of your head, portion of the samples that had their last STI test in the last 6 months?
I don't have that in my head. But also keep in mind that these are people in an ongoing longitudinal cohort of the M study. So part of the M study visits are, do they test for STDs? Yeah, I don't remember at the moment.
So they have an interview and they report location?
Yes.
Okay.
Yeah.
Can you talk a little more about what's included in substance use? Does that include alcohol?
Yeah, it does not include alcohol. So we're doing some more qualitative work here. And for instance, do you count poppers as substance use? And so it does. It includes, the M study has a whole battery of specific questions about all different types of substances. I believe this measure doesn't include alcohol, but it does include marijuana. So, and then all of the other things like cocaine, methamphetamines is definitely the most commonly used illicit substance besides marijuana, and less so fentanyl, heroin, that kind of thing. Which makes, when you think about sex risk and substance use, methamphetamines is really the one that people are most worried about. Yeah.
I don't think I've seen it on here. Do you know anything about these people's income? Like how they're lower income, higher income?
I didn't include it here, did I? I mean, because it's was kind of a higher risk cohort with people using substances, the income is a little bit lower. But I don't have that here. I'm sorry. Okay. Okay, so these are the first set of 4 clusters. These are lifestyle locations, and then the next slide is healthcare. And so what we did is first we just showed you what these clusters look like in space. You cannot see that very well at all from where you are. I'm sorry, but I can describe them. And these data on the right kind of demonstrate that we were able to get a lot of these data reported. So everyone reported where they lived at the moment. 73% reported their last sex location, same with substance use. And interestingly, only 60% reported their last place of socialization. So out of all of these people, there were either 2 or 3 out of those who reported these locations, we found 2 or 3 clusters for all of these lifestyle locations. Yeah.
How is defined social? Like, is it different from sex? Because like, if it's just meeting someone, then
they could say it was the same place. So where did you last socialize? It was the same place I lived, same place I had sex, same place I used substances. But we asked it in a different way, like, where the last time you engaged in a social activity, where were you?
Okay.
Where did you go?
So do you think maybe the low response is what I consider a social activity? Because,
Yeah.
I mean, maybe just having drinks with a few friends is not,
Yeah.
I would not consider it a social activity.
Yeah, especially if it was at my house or,
exactly. So I don't know.
Yeah. Yeah. Good point. Yeah.
You collected the last sex location, or did you collect many?
We asked most 3 recent, and this is most recent. Yes. Yeah, Randall.
I'm curious, so I see the overlap clearly between the clusters in the aggregate, but of course, it's certainly possible, if you looked at this at the person level, that all the people in downtown are having sex in Hollywood and vice versa.
Yes.
Have you looked at that?
Yes, no, but it's on my list because, and that's actually one of my kind of take home findings. I'm like, we could see this overlap, but that doesn't tell you if an individual is, but we can just at the aggregate talk about on average, the characteristics of the people who are engaging in these places that overlap. Yeah, so interesting. Yeah, and I did in the past look at an individual level, like whether or not somebody reported engaging in sex at home or away from home, for instance. I'm not talking about that today, but we could do that as well. So there's a lot of different options to move forward with these data. Okay. So anyway, so the lifestyle locations, there are only 2 or 3 on average for each of these, but they're more kind of distributed around LA County, especially compared to the healthcare locations. But fewer people contribute to these clusters. So, only 20 or so %, if they're reporting this activity, that their activity fell in a cluster. That makes sense. So, out of 219 people who reported where they lived, only 20% of those people's homes were within a cluster. So that means it's pretty, it's more diffuse. Okay, is that what I wanted to say here? Yeah, as opposed to healthcare locations. So the numbers of people reporting these locations, HIV 75%, medical care 98%, so on. But the number of clusters are larger. STD test is lower, but a medical care, we saw 6 clusters as opposed to 2 or 3 for the others. But more people, if they reported these locations, their locations were in a cluster. So, which makes a lot of sense because if you think about, the built environment that's required, it's that's where the hospital is, that's where the pharmacy is. So that's kind of our hypothesis as to why it's less diffuse. The places where men may engage in social behaviors were more spread out, and healthcare places seem to be more aligned in space. Yeah.
It's just so interesting. Your STD test loses that downtown cluster. Do you have any suggestions?
Yeah, so interesting. So the downtown cluster, as I'm going to talk about at the end, has 7 out of 8 of these activity spaces overlapped, except for STD tests. And I don't know why. Yeah.
Like transportation in general for all this, like I live in West
Yeah.
Hollywood and
Yeah.
you see that like sex was happening in Hollywood, and then they
Yeah.
go to West Hollywood.
Yeah.
to Have their HIV test.
So we haven't looked into it yet, although we did ask about the transportation. So if any grad students here want to look into that. Yeah, I mean, it's huge. LA, right? It's hard to get around. I mean, Jamie was telling me no one walks, right? Like how, if you don't have a car, I mean, I guess your metro is getting a little bit better, right? But like, how do you move over space and time? So it's like kind of the geographic concept of the space-time prism, like what's the places that are even accessible to you in space and time, but also, you know, perceived places where you're welcome or where you can do things. Yes, there's a lot of intersecting concepts here. Yeah, in the back.
My first thought is, so you have like this, small sample that's like disproportionately low income. And maybe I like think that I get medical care close to where I live. Have you thought of replicating this using the ACS? And just seeing that like, you can use census tract to see if these like, I'm afraid like some of this maybe like caught like sampling error.
Yeah.
But-
Yeah, no, I do. I think you're so right that we can't just say this is the fact, you know, this is just the individuals that we sampled and they're not representative. But like I mentioned, the new grant we have is actually going to do, we're going to take ACS data and layer them on to understand what the context of these places are. And then also part of the grant is to do an intervention looking at the geography of where people get care and whether health outcomes vary based on that geographically changed location. So, yeah, yes.
Are you able to overlay this at all with like available resources for like medical care?
Not yet,
Okay.
but that's a good idea. Yeah, because you know, LA County also has done a hotspot analysis to try to understand where people who are living with HIV live. And I've only looked at it. I haven't done an actual study to see how much our findings overlap with theirs. Yeah. Yes. Hi.
Over how long a time period do these movements occur? Are you looking like on a typical day and then the day of the week?
Yeah, well, that's another unknown. You know, we say when you last engage in sex, when was it? So we don't have that timing. And also a huge thing that's missing here is the duration of time people spend in these places. So, you know, this is a trade-off where it's a one-time study, we get some information, whereas other ways to collect activity-based data are, you know, GPS, where you get a gazillion, you know, points. You may be a little overwhelmed to draw in data, but you might know a little bit better about duration of exposures, and which is really important too. And the timing of it, yeah. Randall.
One thing I'm struck by, and this may be getting too into the weeds, but anecdotally, the account you hear is that people's mental map of clusters serving this population would include downtown Hollywood, West Hollywood, and Venice.
Yeah.
And Venice is notably missing from this map. And I can't tell if that's real, that maybe I have like a West Side bias, or whether, even though I spent a lot of time around town, or if there's some kind of artifacts, say, of the sample combined maybe with the clustering cutoffs and because Venice is a more sort of diffuse space than like West Hollywood.
So I can't answer the question definitively, but I'm going back to our qualitative study, which, you know, I read and listened to all of them. I don't recall Venice being mentioned once. I remember Long Beach being talked a lot more. Downtown, South Central, Hollywood, downtown, but really very little.
Could that be related to where you're recruiting them?
Could be,
I mean,
yeah,
that's the
exactly.
thing, like you're just recruiting people that aren't in that cluster.
But also, I think the rate, race, so just explain.
Good point. Yeah. Okay, so the next step is to describe, you know, if somebody gave me, say, their home location, is that person's home location within a cluster or not? So these are bivariate logistic regression models that are unadjusted. So these are just, you know, not each of these is its own model. It's basically what I'm saying. And the really interesting thing is that for almost all of the lifestyle locations, Hispanic individuals' activities were less likely to be in a cluster across the board, whereas Black individuals were much more likely to have their behavior fall into a cluster. So I really do think this is interesting, and it has a lot of potential implications for thinking about, harm reduction strategies for substance use. Like where, if you wanted to geographically target a location for substance use harm reduction, that might work differently for different races and ethnicities. We see unemployment. So these are people who are unemployed, and the reference category is if they're employed. So people who are unemployed were much more likely to report engaging in sex within a cluster and using substance within a cluster. So that's also quite interesting. For HIV outcomes, the only thing that kind of came out here was people with detectable viral load. So no, not all of you are HIV epidemiologists, but if someone has detectable viral load, that means that either they don't know they have HIV or they have HIV but are unable to adhere to medication. And if someone has detectable viral load, they're able to infect others and probably have worse health outcomes themselves. And so that is very much associated with engaging in substances within a hotspot. Yeah.
Do you have a measure of isolation in general? Because I'm thinking like this unemployed, disability, and also I guess it matters whether you're someone more or less isolated.
Yeah.
You're more likely to have a cluster that is your home.
I love that question. No, we didn't ask about social isolation or loneliness. Some of my qualitative work right now, we're doing all of that, but maybe the next round of surveys for this would be really interesting, right? Especially because social isolation and loneliness are two different things as well. You may be around a gazillion people, but still feel isolated, which is bad for your health. Yeah, that's a great question. Yeah.
One point in the front slide, but I was thinking anyway. How granular can you get when someone reports the location of their last sexual encounter? What kind of information do they typically give you? I mean, it's interesting because they could say, they could give you someone's address to a house, or they could give you a park. Or a bathhouse or something. Right. And then you would have some identity, well, they're cruising, in which case there's probably some kind of safety, sexual safety. That's compared to having sex with someone in the house. If you're in the park doing it, you're probably engaging in a little bit more risky. Right.
That's such a good point. So for this, it's simply just the XY coordinate. But as I mentioned before, I could do an individual level analysis that says, is this location at your home or elsewhere? And if it's elsewhere, if we have enough power, we could differentiate between these places.
Right, so it's not their home, it could be someone else's home.
Yes.
That's not, that's kind
also,
of, not that, I mean,
You're totally, yeah.
Hispanic versus Black result.
Yeah.
So Los Angeles County is about half Hispanic, about 10% Black. So I usually wonder if there is a segregation, if you get something almost mechanical there, where if someone who's Black needs to use Black, you have to go to a hotspot.
That's such a good point. Yeah. Interesting. Yeah. That's a really good point. I hadn't thought of that. Thank you.
Just to build on that, I think it would be, you could maybe put that in the language of kind of racialized or racially safe spaces that that African-American spaces would be quite easily defined and bounded.
Or even just a racial isolation index.
Yeah, great. Substance use, people who use substances weekly or more. The only thing here is if they if they offered a sex location, that sex location was within a hotspot. So that means, maybe there's potential places where, interventions could focus both on substance use and safe sex. Let me get to my notes so I don't forget anything. Housing. So, people experiencing housing insecurity have higher odds of engaging in sex and substance use within an identified hotspot. So, as I don't have to tell you guys, housing seems to be a problem here in LA County. So, although our work doesn't necessarily talk about housing interventions, these concepts could be used to inform some type of harm reduction that synergistically or, addresses some of these syndemics of housing and substance use. Yeah, so, I think this is pretty clear. If someone met their partner online, then maybe they're less likely to have live, no, actually, I'm confusing that. Less likely to report living in a hot spot for home. So that's interesting. And if they are in a casual partnership, then I'm more likely to engage in substance in a hot spot. Yeah.
I'm gonna ask you about this after.
Okay.
But do you think you have data to do these sorts of tests on possible membership to higher HIV risk group? Namely, like people who don't test quite often, who have less contact with like sexual health resources, or who are perhaps like a down low person.
Yeah, we do have whether they've come out or not as a variable. It's not in here. Yeah, you know, our sample size isn't huge, so we definitely are limited by the ways we can stratify. But I'm sure we could look into some of those. Yeah, okay, thanks. Okay, and so then the next one basically is that hotspot membership in healthcare locations seems to be much less patterned by socio-demographic variables. You still see a little bit of the race and ethnic signals, but otherwise the only thing that emerged is people who are living with HIV have maybe special clinics that they go to, whereas their healthcare and their pharmacy are within a identified hotspot. Is it, what time is it's just about 2, right? Maybe 10 minutes left or less, or how are we doing the time? Okay, I'll try and finish up a little bit. Oh, 11, wait.
15 minutes.
15 minutes, great. Okay, so the second question is to ask whether these places overlap. So let me just orient you to this bubble chart. So, an overlap is defined as, the overlap between, say, the home hotspot and the sex hotspot as a proportion of the home hotspot. So these are the I's, these are the J's. So for example, the substance use hotspots contained 55% of the home activity hotspots, or you can flip it around and say the home activity hotspots overlaps or shares 55% of its total area with substances. But if you flip around the reference, because the overlap of I of J is not equal to the overlap of J with I. So up here, so the home activity hotspots contain, bless you, 76% of the substance use hotspots. So one thing that's important to think about is that the identified hotspots for home were the largest in extent. So because that's the largest denominator, that's where you see the most overlap is along this column. So but you could also say, well, then maybe that's good news. Like 80% of the pharmacies hotspots are located within the home hotspot. So maybe people don't have to go so far to get an medicine or something, or maybe some healthcare intervention that's oriented through a pharmacy. We do see more overlap between lifestyle hotspots and other lifestyle hotspots, and medical hotspots with other medical care hotspots. What was some of the other things I wanted to say? But we didn't see a lot of overlap or congruence with social locations or hotspots with other places. Yeah.
Could you help me with the intuition of why we don't see symmetry?
Yeah, okay. So because of this equation here, so the reference category is the hotspot I at the bottom. So the proportion depends on how big that hotspot is or how small that hotspot is. So if I'm looking at, what proportion of home locations exist within the extent of the substance use locations is only 55%. But if I'm looking at how many substance use locations are within the home locations, it's going to be higher because the home locations are larger. Okay. I mentioned the home. Socialization appears to have minimal overlap with other locations. The sex hotspots are almost entirely contained within the home hotspots at 98%, but only moderately, say, with substance use. So that's interesting. So we have a slightly change there. Most of the healthcare locations don't overlap much with substance use, which is interesting as well. Although I already mentioned the pharmacy up there. So hotspot congruence or overlap was definitely higher than we expected. And it raises some interesting questions about potential, policy implications. Home, sex, and substance use hotspots had the highest level of overlap, ranging from 55%. So substance use hotspots were contained in sex hotspots. Let's see, substance use and sex here and here, up to 63%. But as actually Randall mentioned earlier, hotspots being congruent doesn't necessarily mean at an individual level, and an individual is engaging in both of those activities in this one hotspot. So it's really important to remember that we're looking at an aggregate level here. So that's something that we could do in the future. Okay, so this is the last kind of main slide. And so this is taking all of the hotspots and then overlapping them with each other. So just visually, we identified 4 kind of main themes here. We've got the downtown area, the Hollywood area, and East and West Hollywood. And so downtown area, as actually Jamie mentioned, has 7 of the 8 hotspots within the area, whereas the West Hollywood area is only social. That's only social. So, if you're trying to think about potential geo-targeted interventions, you'll have very different strategies depending on where you're going. So we just did some basic descriptive statistics of kind of trying to describe who is engaging in this hotspot, regardless of which activity they're in. This is just kind of describing these places. So for the downtown area, as I mentioned, 7 of the 8 hotspots are represented, except for STDs. And then on average, compared to an individual not being in the downtown hotspot, these individuals were more likely to be Black, unemployed, and experiencing homelessness compared to the others, and having casual partnerships. So, our findings might suggest that, a housing related intervention might be useful for this area, as well as like harm reduction strategies for substance use or HIV related interventions culturally tailored to Black sexual minority populations. Okay, so East Hollywood, this is mostly healthcare related, is where social HIV tests, medical care, pharmacies were the places that were found in this general area. Individuals engaging in these areas were less likely to be Hispanic and more likely to be Black. And these are small sample sizes. So something really, as I mentioned before, the caveat that we need to be very careful drawing larger conclusions. These are just the hotspots emerging from our sample. So similar to the downtown area, the Hollywood area had 7 out of the 8 activity hotspots there, but the sociodemographics were very different. People engaging in these hotspots were much more likely to be living with HIV and engaging in casual partnerships. So, interventions here might be focused more on preventing secondary HIV transmission. And this population is older as well. And then lastly, the West Hollywood location is really only the social location hotspot, but much less likely to experiencing housing insecurity, much less likely to be worried about housing. Just seems like more well-off kind of housing issues here in the population in general. Higher education, less likely to be unemployed. Okay, so that's it. Just I wanted to just demonstrate how we approach this study. We do find distinct spatial patterns among Black and Hispanic men. Most of the patterns were, though, around lifestyle-related hotspots, whereas the medical and health intervention hotspots were much more diffuse and with less patterns. We demonstrated how these location and spatial extent of hotspots differed, and the memberships differed, and the overlap was not quite what we expected, but I guess 50 to 65%, in LA County, is that a lot? Is that a little? It's really hard to say, especially since a lot of our previous research was in New York, which is a very different concept. And so we do identify, these 4 areas. which could be prioritized differently for different interventions. But of course, you know, to do this again with a representative sample or some other type of sample would maybe be something that, you know, LA County could adopt. You know, some of this might be affected by COVID. The isolation thing that you mentioned was interesting. We did talk about duration and timing of these behaviors, and we didn't characterize the spatial uncertainty, which I mentioned, you know, the uncertainty might be a function of the location type, the behavior occurring in the place, or the person. So all of those things could matter. But I just wanted to end up saying, you know, we demonstrated this valid and it's cost effective for measuring the spatial extent of certain behaviors. And I just wanted to go back to some of my motivating things, that spatial data is really becoming more and more readily available and can really improve some of these health interventions. A lot of calls for proposals I've seen are asking about like geo-located interventions. You know, there's this concept called geofencing that I just recently learned of, you know, where if someone walks into a boundary, some predefined boundary, then maybe they'll get a intervention that says, oh, did you know this is where you could go get this, you know, vaccine or something like that. And then of course, contextually responsive health interventions, just going back to the socio-ecological model that our health is more than who we are, what we're doing, it's the context in which we're living. And I just wanted to finish saying thank you to the M-Study participants, the M-Study staff at the LGBT Center and UCLA Vine Street Clinic, my colleagues, our funding mechanisms. And I just wanted to mention that we just got another one to do some more of this contextual level work with the intervention. So I look forward to working with Pamina and Marjan, who I don't know if many of you know her. She works here at UCLA, and our colleague at Santa Barbara. Okay, thank you so much for coming.